Thank you very much to the chairs and also to the organizing committee. This has really been a very interesting and very topical conference. And I think the focus on prevention is really very important. So I'm going to try and highlight the updates in the diabetes therapies, which are really important to us, both from an internal medicine, cardiology, and endocrinology perspective. So I'm going to start with this very important real-world study. It's called the Capture study that looked at the prevalence of cardiovascular disease in people with type 2 diabetes. This is a very large study, 13 countries, 5 continents. They looked at almost 10,000 patients with type 2 diabetes, and they looked at primary and secondary prevention care as well. I have to say that for the first time, the Middle East was represented with a very robust representation from our friends in Saudi Arabia and Turkey. So the ultimate outcome of this study is that 1/3 of all people seen in these clinics in real world practice actually had established ASCVD, cardiovascular disease. 9 out of 10 patients with diabetes and cardiovascular disease actually had atherosclerotic cardiovascular disease. The minority were diagnosed with heart failure or vascular disease or atrial fibrillation in an outpatient setting. Unfortunately, 2 out of 10 patients, only 1/5, with diabetes and cardiovascular disease were having a medication with proven cardiovascular benefits, in spite of all of the strong recommendations in every society, from cardiology to diabetes to endocrinology and nephrology, to recommend GLP-1 and SGLT2 inhibitors in diabetics with cardiovascular disease. Now, one of the key points to remember that if you look at a patient with cardiovascular atherosclerotic disease, it's a precursor to heart failure. Because if you look at prospective registries of patients with diabetes, 7 out of 10 patients with diabetes and heart failure had a prior history of MI and heart disease. So preventing ASCVD will prevent heart failure directly and indirectly, and I think this is a critical, important point. I'd like to share with you some data from the UAE, and this is just to highlight the importance of this problem. 30% of adults in the UAE are at risk of cardiovascular events. 40% of the population actually in the UAE have cholesterol levels well above the recommended targets, which Dr. Haytham very nicely showed. Cardiovascular disease represents 39% of all deaths in the UAE. And the DALYs, which is the years of life in the UAE from ischemic heart disease and hypertensive heart disease, are 3,700 per 100,000. 3/4 of cardiovascular disease is fully preventable, and therefore there's an urgent need to address cardiovascular disease through prevention and public health in the advancement. Now, this was presented very nicely by Dr. Haytham, but I'm going to take a little concept of this from the ESC guideline. Diabetic patients in the ESC cardiovascular protection guideline, the primary prevention guideline, and the lipid guideline are defined as high risk if they have no target organ damage, or if they simply have more than 10 years duration, of their diabetic with a single risk factor. That means practically all diabetics are high risk. Diabetics with target organ damage, such as microalbuminuria, retinopathy, neuropathy, or LVH, or diabetics with multiple risk factors, age, gender, high cholesterol, high triglycerides, obesity, long-standing type 1 diabetics, 20 years, and of course, diabetics with peripheral artery disease, ASCVD, and CVA are extreme high risk. The tragedy is that these patients are there, but we are really failure to prevent it. Now, I'm going to go back to the therapies that have been shown in the studies and evidence in clinical medicine that are beneficial in patients' cardiovascular event reduction. So, MACE, GLP-1 receptor agonists and SGLT2 inhibitors, significant reduction of MACE in the cardiovascular outcome studies. Non-fatal stroke, significant reduction with GLP-1, but not SGLT2. How about non-fatal MI? Again, SGLT2 and GLP-1 receptor agonists, and this is meta-analysis, not individual studies. And heart failure hospitalization, significant, really powerful for SGLT2, slightly less with GLP-1. So across the board of cardiovascular events seen in the guidelines and the studies, these are very powerful risk-preventing therapies. However, only 2 out of 10 patients are getting these drugs in the modern era. Is it because of a shortage of data? The answer is absolutely not. So we have here highlighted in blue are the GLP-1 receptor agonist studies. In light blue are the SGLT2 inhibitor studies. In orange are the DPP4s and other therapies. So it's entirely clear that there's a vast number of patients, both in terms of duration, intensity, type of therapy, where we have seen that the 2 classes of drugs that are SGLT2 and GLP-1 have a tremendous impact on cardiovascular disease and obesity outcomes in diabetic patients. Now, the ESC guideline has taken this a little bit further, and you may disagree with this approach, but in a patient who's newly diagnosed with diabetes, who has either a cardiovascular event, or high and very high cardiovascular risk, or target organ damage, or multiple risk factors, you should primarily consider SGLT2 or GLP-1 receptor agonists. And then, as a next step, adding metformin. The patients do not have to go to metformin except once the A1C is needing to be required. And that's a little bit controversial, and maybe the endocrinologist can correct me, but I think the key point is that they have weighed the evidence and they have decided that the evidence is strongly in favor of risk-modifying therapies to be started first and avoid therapeutic inertia. Specifically, SGLT2 inhibitors and GLP-1s are recommended in drug-naive patients with ASCVD or high and very high-risk diabetics as first-line agents, even if they have not a cardiovascular event, but they fulfill the high and very high-risk criteria. Now, the majority of patients, to be honest with you, are already on metformin, so this may be a moot point. However, if they're on metformin and are recognized to have atherosclerotic cardiovascular disease, high or very high cardiovascular risk, so target organ damage, multiple risk factors, go again to add SGLT2 inhibitor or GLP-1 receptor agonist. And then, if the A1C is not a target, add the DPP4, add the insulin, add the TZD as appropriate. Again, this is not a glucocentric approach. This is an early risk reduction approach, and it's extremely important, irrespective of the HbA1c. I think this is a key point to emphasize that anywhere on the treatment spectrum, early or late, patients with this profile have to be on disease-modifying therapies. And this is given a class 1A level of evidence recommendation for the GLP-1 receptor agonist and the SGLT2 inhibitor. This is a key point because this is the reduction of cardiovascular death and cardiovascular events that is driving this recommendation. Now, SGLT2 inhibitors have had a lot of clinical studies. So we started with EMPA-REG, we've had CANVAS, DECLARE, CREDENCE, VERTIS, CV. These are the diabetic outcome studies, okay? And in reality, the studies have been very efficient in showing non-inferiority in terms of heart failure hospitalization, particularly, as well as renal-related composite endpoints. Now, CREDENCE was a specific renal study in which cardiovascular disease and heart failure was seen to be positive also. EMPA-REG had significant reduction in heart failure. VERTIS had significant reduction in heart failure. CANVAS and DECLARE did not specifically look at heart failure, but it was labeled under the cardiovascular event group as well. GLP-1 receptor agonists. Now, this is a profusion of different GLP-1 receptor agonists. So we have different agents with different profiles. So we have the LEADER study showing the liraglutide, the SUSTAIN 6, which was semaglutide. We have PIONEER 6, which is oral semaglutide, plus the older therapies such as exenatide and Lixi. We also have REWIND, which is dulaglutide, and the Amplitude O and Harmony. So there's a lot of different agents here. This is a complicated slide just to show you that the different agents looked at different types of patients, and we had patients with established cardiovascular disease in the majority, except for REWIND, which actually had less patients with established cardiovascular disease and more primary prevention patients as well. So the overall meta-analysis of the GLP-1 receptor agonists, all of them reduce triple point MACE, which is fatal and non-fatal stroke, fatal and non-fatal MI, and cardiovascular death. There you go together, almost a 16% reduction on top of standard of care, except for Elixa, where this was on the wrong side of the line. Now, if you take, again, all of the GLP-1 receptor agonists, cardiovascular death significantly reduced with Amplitude, PIONEER, REWIND. Overall, as a meta-analysis works, 13% relative risk reduction. That's kind of an important point to remember. Fatal and non-fatal myocardial infarction, again, meta-analysis overall positive. And stroke is a unique feature of the GLP-1 receptor agonist that we didn't see with SGLT2 inhibitors because of the vascular reduction effect from LEADER, SUSTAIN, EXCEL, HARMONY, REWIND, PIONEER, and Amplitude O. Clearly, this is a class effect, except for this one, which is Elixa. So it's a specific problem with this agent, but all of the other subsequent studies and agents, which are highly specific, showing a massive reduction in stroke. All-cause mortality, again, overall, a 12% reduction, regardless of the type of GLP-1 receptor being used. The renal outcomes of GLP-1 receptors are very important also. Composite kidney outcome, including macroalbuminuria, is significantly reduced in these clinical studies, again, by almost 17%. And I'm going to take a little bit of a deeper dive on Sustain 6 and Pioneer. The Sustain 6 looked at semaglutide as a cardiovascular outcome study, including patients with diabetes, ASCVD, and renal failure, or multiple risk factors. And the Pioneer 6 looked at a similar group of patients using oral semaglutide, which is another very innovative way of delivering the protein instead of injection. There was a significant 2% absolute risk reduction and a 26% reduction of non-fatal MI, non-fatal stroke, and cardiovascular death. If you looked at the individual endpoints, non-fatal MI was positive, non-fatal stroke was extremely relevant, 40%. The expanded composite endpoint was also significantly improved. CV death was actually neutral related to placebo. Pioneer 6, which is an oral GLP-1 receptor agonist, again, a smaller study, a more rapid event rate accumulation, again, a 21% reduction of the relative risk reduction here, and a 1% absolute over a short period of time. And here, we saw a really big reduction in cardiovascular death, although the event number is pretty small. All-cause mortality was almost 50% reduced with oral semaglutide in addition. So both together were pooled in an important meta-analysis and showed us the significance of that pooled meta-analysis. And if you take them both together, they're all internally consistent. So MACE was reduced by 14%, basically very similar to both studies. CV death, similarly, non-fatal MI and non-fatal stroke. So directionally, it seems to work that it's the same agent, but being delivered through an oral therapy. Now, taking both together, again, injectable or oral, MACE, with or without evidence of CVD, was being reduced by 15%. Prior MI or stroke, more effective if there was none, but still works if they did. So effective in primary prevention patients and also with prior heart failure or not. No really significant p-value for interaction. So what is next? We are now in the phase of the SOUL study. This is an oral semaglutide cardiovascular full outcome study in patients with type 2 diabetes who has established CVD or established CKD, and they've started in 2019, and it's a 5-year event-driven study. And this is going to look at cardiovascular death, non-fatal MI, and non-fatal stroke, as well as limb ischemia and CKD as well. We still don't know the results of the study, but judging by what we've seen before, I would imagine this would be a very powerful outcome. So the summary of what we've looked at in the pooled analysis of the GLP-1 receptor agonist is a reduction of cardiovascular outcome by 26%, non-inferiority of the oral semaglutide by 21%, so very similar in directionality and proportion, 24% risk reduction of MACE with semaglutide in the Sustain 6 and Pioneer 6, and then looking at semaglutide really in the high-risk diabetic patients, and probably even now we will see studies in non-diabetic patients and CKD as well. And thank you.